Welcome back to the Full Code Podcast YouTube series. Don't really have a name for it. Today, I wanted to keep going through some of these case study mediums, I guess you would say, so that we can just do some thought exercises, walk through things, but also as kind of like a preview for the things that are out there. There's a ton of great things. I think when we think about medical education, we get caught up in thinking about some of the things that we've had to go through as far as maybe various types of health streams or certain trainings that are offered by specific organizations, maybe that we have to renew every 1 to 2 years and get stuck working in systems that maybe don't work so well. But there's a lot of stuff out there that works really well. So the one I want to talk about today is full code medical simulations. Now, obviously not related to this podcast, entirely separate entity. We're not endorsed by them. This isn't a paid advertisement of any kind. This is just a product that I pay for that I really like. I've done many of these with a lot of you all in real time. It's fun. And honestly, it's something that highlights what we're capable of doing with technology and how we need to encourage the bigger organizations with the deeper pockets to get more invested in these things that are open to everybody at a relatively low cost. Like, we understand that everything in this world costs money, but one of our goals in doing this podcast and YouTube series is so that we can develop some more easy to access venues for learners across the spectrum who are interested in the topic and don't want to spend hundreds, maybe even thousands of dollars on certain courses, but we can still hopefully add some value to your practice. So I'm going to change our screen so that we can get right into this case. Okay, we are in. So I'm going to read through it. You should be able to see it on the screen as well. If you're not familiar with this format or with full code medical simulation, I will walk through it with you so you understand kind of the groundwork of what we're doing. But I'll start with the case introduction first. This is information from the floor nurse, I guess. It says, on reassessment this morning, patient has developed a high fever and tachycardia and has activated a rapid response. Now, when I selected the case, it did tell me, hey, this is a patient that's been admitted for, I believe it was acute alcohol withdrawal, but it will reiterate that when you go through your case selection menus. It says, RRT nurse, 47-year-old who's been admitted 3 days ago with alcohol withdrawal, now with fever this morning and tachycardia to the 140s. Current access is a right IJ central line. That feels a little foreboding. So let's go ahead and begin the case. Now, when you go into these cases, you're going to see a simulated patient, and obviously the context of this is that this is in the course of a rapid response. So we are walking in to see this patient. You can see that the patient has a monitor next to them, but there's no continuous vital sign monitoring. I know for those of us in the ICU, it kind of throws you off for a second because you have to think about the things that you have to manually do that before you just always had access to and are always there. So on the left and right sides of the screen, there are tabs for patient. So it's going to give you more intel on the patient. Exam, and that's, actually, let me pull it up. So, nope. No AI conversation. So the patient tab is going to give you more intel on the patient. We will go through this. There's also a review of systems here, in addition to the next tab, which is the physical exam. Now, for those of you that don't know, we often do both review of systems and physical exam. The review of symptoms is essentially what the patient tells us. So when we say, have you had any cough, fever, shortness of breath, general weight loss, changes in hot or cold perception, things like that, those are all subjective findings. The physical exam is our objective findings, like what we are observing, what we are finding. The third tab is stabilization. So we have insert IV, attach monitor, start chest compressions if this patient was having an arrest, oxygen, fluids, pacer, vascular access, intubation drugs, call for intubation. You have your differential tab. So as you're going through this, we're going to build a differential diagnosis because ultimately we have to potentially diagnose the patient, treat the patient or temporize the patient, get them to where they need to be with a working diagnosis. On the right side of the screen, we have our investigations tab. So we have bedside test, lab work, other labs, imaging. We have interventions tab, and that's more meds, procedures, blood product administration. Third tab is communication. So that's for if you want to call the consult, which many of these cases will have you do. And then there's handoff. So what is the dispo of this patient? Where are they going? So let's go back over to the patient tab. So we have a hospital day 3. This is Mr. Alan Webster. He's a 47-year-old male, 175 centimeters tall, 72 kilograms heavy. He is a full coat. So he is a 47-year-old male admitted for alcohol withdrawal. Initially, difficult IV access. Initially, it says that twice. Weird. Central line placed by our after phenobarbital load. On hospital day 2, symptoms improved, transferred from intermediate care unit into the telemetry floor. Now on oral phenobarbital taper with anticipated discharge tomorrow. Presents today with new onset fever and tachycardia. Now, as we go through this, I'm going to encourage you to be as systematic as possible, especially if you do this on your own time, you're playing these cases. You want to have a methodological approach to how you diagnose and treat patients. And that applies to everything. That's not just providers. Like when you are, even as a nurse, respiratory therapist, whatever, when you're looking at these patients, you need to have a systematic approach so that you're avoiding redundancy, you're making sure that you're being thorough, and that's going to help you make good decisions. And I say that because, and I have it all the time, you see these patients in the simulation, you want to jump past all that information. Let's get them on the monitor, get IVs in them, blast them with fluids, yada, yada, yada. In this game, you have time, and it's good to help work on kind of your cognitive process and how you think through these problems. So, and obviously in real life, sometimes they are crashing. So for the sake of some sort of high fidelity, let's go ahead and throw the monitor on them because it's a rapid response. That's what we would do, right? Now, so we got some tachycardia. Looks like we're sounding appropriately on room air. Respiratory rate of 22. Temp is 40 degrees Celsius, so a little high, and BP is 121/70. So you know what, first and foremost, let's kill that sound. There we go. So we have a tachycardia, we have a little febrile, little tachypnea, and blood pressure 121/70. Now, always consider that while that is a good blood pressure, we don't know what the blood pressure has been running before this. Maybe this patient runs really high and 120 is actually pretty low for them, but we'll work through it. So back to the patient tab. Progress note, unknown, good. That's not necessarily an uncommon situation where you don't have the best information to work with. Past medical history includes alcohol use disorder, hypertension, IV drug use, and remission, no use greater than 5 years. So that's good to know. But and it is relevant to considering what's going on here as well. Current medications include hydrochlorothiazide and amlodipine. No known drug allergies, non-contributory family history, and he drinks, let's see, social history. He drinks 6 to 12 beers daily. Prior complicated withdrawals with seizure. Last drink 1 day prior to admission. Remote history of fentanyl and heroin IV drug use and remission. So he drinks 6 to 12 beers a day. Now, why is it relevant? And I'm going to be honest, in real life, it can give you a general gauge of maybe potentially how severe a withdrawal syndrome is going to be, but it's not a definitive predictor. I've seen plenty of people who drink very heavily and have very minor withdrawal. They have shakes for a couple days and get out of it. Now, that being said, is that the most common situation? No, because we work in the ICU. So typically those people, by the time they reach the ICU, we've already figured out this isn't going to be an easy run. Now, below this, we have our review of systems. Now, sometimes in these situations, in these simulations specifically, the patient can't always contribute. I will tell you in regard to this simulation system itself, that it wants you to be as specific as possible and not ask unnecessary questions. That being said, I prefer being thorough for the sake of being thorough. Obviously, you need to tailor your approach depending on the severity of the situation, the acuity, how quickly the environment might be changing. Obviously, if this patient was extremely tachycardic, hypotensive, maybe having respiratory distress or something to that effect, like, I'm not going to be like, tell me about your skin. Okay. Any problems with your feet? We're going to address what's in front of us, right? But given this is a simulation, now in these simulations, these patients will crash. He is not crashing. So I'm going to go through the entire review of systems real quick. Let's see. Boop, boop. All right. So constitutional. So constitutional is general. Patient states, quote, I just don't feel very good. I was up all night with sweats and chills. So you ask yourself, and because as you're going through this, you're building differentials in your mind, right? Sweats and chills. Is this alcohol withdrawal related, or is this because of an infectious process? I think just looking at everything, they're absolutely insinuating that this is a ongoing infectious process or an evolving infectious process. Looks like eyes are negative. I won't go through every one of these if they're negative. ENT is negative. CV, he does state that I feel like my heart is racing, which he is tachycardic. Respiratory is, let's see, negative. GI, patient states, quote, I was having a lot of nausea and diarrhea when I got admitted, but that has resolved now. It's very likely related to acute withdrawal syndrome. GU is negative. Neuro, patient states, I was having a lot of tremors when I got to the ED. They told me later that I had a short seizure before I was admitted to the hospital. So alcohol withdrawal related seizure. Okay, skin. Patient states, quote, I have some old scars from drug use, but I'm clean now. They had a really tough time getting an IV when I got here. Now I got this thing in my neck, referring to the central line, which they cited in the very beginning of the case. Musculoskeletal, patient states, quote, everything hurts. I have body aches all over. Yeah. No history of allergic reactions, throat swelling, wheezing, or hives. And then for psych, patient states, I feel in pretty good spirits and was looking forward to going home. Well, you are not going home, friend. Sorry. Okay, so let's move over to the physical exam. Again, just like with the RRS, they do kind of want you to be specific. Thoroughness for the sake of being thorough. I'm just going to click through them all and we'll just go over any pertinent findings. So, neck, there's your first positive. Redness and induration surrounding the insertion of the central line. No masses, trachea is midline, supple with full range of motion without C-spine tenderness. So there's a bunch of flashing signs pointing to this is a central line infection. That's very likely the case. Cardiovascular exam is clear. Pulmonary exam is clear. Skin, erythema, and a small amount of purulent drainage around the right IG catheter site. So that's it. Yeah, this is a central line infection. So what do we do and what do we need to investigate? Now, he's on the monitor. We've looked at his vital signs. It almost looks like, his heart rate actually looks irregular. So we might want to grab an EKG. Obviously, we know our patients that are acutely or even critically, especially critically, they'll have a propensity to develop atrial fibrillation or AFib with RVR, which is very problematic and life-threatening. He's not hypotensive. Now, does that mean we're not going to give him fluids? No, because this is very much painting a sepsis picture. And we all remember the components of our sepsis bundle. If not, we will go over them. But let's go ahead and get through a couple things first. So, and just as a note, when you go through these investigations and interventions, a lot of times they'll change just based on the scenario. And honestly, if you're struggling, sometimes that can be a clue. Whenever you see something that's not usually there, you're like, I wonder why that's there. So, bedside tests. Let's grab an ECG. And then for lab work, Now, what do we need to check when we're concerned for sepsis? Lactic acid. Now, do we need to do a full panel workup? Right at this moment, there's not enough info to substantiate that. But we have to consider the nature of what we suspect is wrong and what we should do. So what do I mean when I say that? I mean that even though this patient is just tachycardic and normotensive, that doesn't guarantee that they're not going to have some sort of lactic acidosis. That doesn't necessarily indicate that they're not going to have some sort of underlying organ dysfunction. So those are things that you have to anticipate. A lot of times, and it's not really this way anymore, and obviously it changes from system to system, but for example, one of the hospitals I worked at a long time ago, if your patient met sepsis criteria, it would fire off a very specific barrage of labs, but it wanted to see renal function, it wanted to check bilirubin, it wanted to check lactic acid, because they wanted to look for any sign of ongoing early sign of organ dysfunction. So for the sake of kind of what you would probably see in real life practice, we'll go ahead, we'll get a basic chemistry. We don't really need a calcium level. You don't need a coag panel. He's not bleeding. We can get a CBC. We'll look for maybe some leukocytosis. Obviously there's no one data point that's definitive for making this diagnosis, but often we have to make a compilation of the data to create an accurate diagnosis. Yeah, put in a lactate. Lipase, that's something you could consider. He did come in for acute alcohol withdrawal. He may have some degree of pancreatitis. It's not really insinuated. He has a normal abdominal exam. No signs of that, so I'm not going to check that this time. I will check liver function. We'll just spot check that. Given that his heart rate is somewhat irregular, we'll also check his magnesium. You don't really need to check a FOS level. There's really no indication here. A lot of people look at FOS and they're like, well, what does FOS do? FOS, in the ICU setting, when you have a patient who has really low FOS levels, it can be prohibitive of liberation from the ventilator, because you can get some degree of diaphragmatic weakness. But by and large, for us in the critical care unit, derangements of serum phosphate levels they don't do a whole lot for us, except for in certain specific circumstances. Let's see. Troponin, urinalysis. I'm not going to get a urinalysis because I think we already have a pretty good idea of where his infection is. Let's see. We need blood cultures for sure. There are some places that will get CRPs. I'm not really going to go down that rabbit hole because some people will tell you that it's a signal for some degrees of inflammation, but it in many contexts lacks sensitivity and specificity. But it's not, in some people's view, it's not completely useless. It's just not something that's a part of the standard of care. COVID-19 test, no. We will get, we don't need a CK. Looks like we have some cerebral spinal fluid studies, sometimes SED rate, but again, not part of the standard. Those are all little rabbit holes that you can go down. Dun, dun, dun. Okay, so let's go ahead and fire off these investigations that we have. Oh, geez. So whenever you do different diagnostics, it will give you not an interpretation. It will give you an image. And just, I'm going to be honest, the image doesn't always match what maybe you're seeing on the monitor, but the image is definitively what's going on. So don't get tripped up by the monitor, because you could just be seeing a sinus arrhythmia with, existing sinus tachycardia. But this one reads, and I'll have to double check my settings. When you're playing this game, you can change the settings to how difficult you want it to be. A lot of times when I play it, I don't put any interpretive measures on it, just to kind of push me a little bit. But this one says sinus tachycardia with short PR interval, marked left axis deviation, abnormal ECG. Okay. And obviously whenever the machine spits these things out in real life, I don't know, I wish there was a breakdown on how many times it says something like critical finding or acute MI when it's actually not. But it's good, I guess, in the sense that it gets your attention and gets you to look at it. Just spot checking this, I don't really see any huge abnormality. So let's jump over to the side. Blood cultures in process. Obviously, we're not going to get those immediately. Magnesium 1.9, maybe could use a little bit, but that's really not important right now. No transaminitis, liver function is normal. White counts 37. Okay. H&H is good. Platelets are good. Chemistry looks fantastic. Renal function looks fine. And we already looked at the ECG, and our lactate is normal. So what do we do? Because this patient clearly has an infection, right? Now, for a one positive finding, really, which is the white blood cell count, we got a reading of 37.2. Now, I've been asked before, we've talked about this maybe a little bit, at what number do you start getting concerned? And I'd say the general answer is any that's abnormal becomes a data point that you need to find another data point to connect it to, so that you can either prove or disprove, i.e. sussing out its clinical significance. We have discussed in previous podcast episodes about the concept of stress demargination and the factors that go into this kind of stress-induced release of these cells into the bloodstream, causing an elevated, like in this case, an elevated white count, but that it's not truly indicative of an ongoing process. It is just a stress response. Now, in this case, 37 would be enough to get anybody to go, huh? That looks like it's important. And there are arbitrary numbers, like I know we've discussed. For me, like if you're over 20, I have a little bit more of a concern. So a good example would be patients with the acute DKA often come in, and those are patients that you cannot immediately exclude sepsis on, but it's not always present. So when you have those patients, and we won't turn this into a DKA study, but they often have elevated white counts, they can be hypotensive, and all those things can be often easily explained by what's going on, but it does create an environment where you have to think in the back of your head, do I need to at least exclude sepsis, or do I need to treat as if it was real? Because one of the 5 I's of DKA is infection, because any infection can have this as a resultant effect. So the other thing is, whenever you see white counts that are like upper 30s, 40s, 50s, 60s, especially in the like upper 40s and 50s and 60s, that's when you start looking at the belly. So is this C. diff colitis or something to that effect? So let's see. This guy's just been sitting here the whole time staring at us like, gosh. So what do we need to do? Now, this does invite us to talk about the differentiation between different maybe tiers of infections, or that's probably not the best way to put it. But what do I mean? So when we have patients that come in, we get called on uncommonly for patients that people are like, oh, they're septic, right? And a lot of times what they're saying is, if they don't have a source, a lot of times what they're saying is, you meet SIRS criteria, so we presume that sepsis is present. Now, just because you are SIRS positive doesn't always mean that there's an infection. And SIRS is not always considered to be synonymous with sepsis. And honestly, it shouldn't be. Let's jump back into getting this guy squared away. So like, our ICU brain is like, we gotta give him a fluid bolus and all this stuff. And I'm gonna be honest, I'm not sure what the game is gonna ask for here, but let me look at something. Let's take a look at the fluids. Normal saline bolus, normal saline 1 liter, D5 NS bolus, D5 half, lactated ringers, normal saline, lactated ringers infusion. So, our standard fluid protocol in sepsis is going to be 30 cc's per kg. This guy is 72 kgs. Let's call it 70. That's 21, so 20. So 2.1 liters, ideally, was what we would give him as a sepsis activation. We do need to consider, and I'm just kind of thinking out loud, in any of these patients, we do need to consider the question, can they handle the fluids? Because it's not against the law to give them less, but you need to have a good clinical reason why. Now, what's one of the things that gives me a little bit more pause than it normally would? One is his drug abuse history. It doesn't, if I remember correctly, it doesn't really differentiate how long and what the severity of his drug use was. It does say he hasn't used in greater than 5 years. We're going to take him at face value for that. But we have to consider that there may be some underlying heart issue that maybe hasn't been discovered yet until you start flooding them with fluids. That can happen. Or maybe there's an endocarditis component, and that could be from having the history. Maybe he did have a relapse. So obviously we've all seen patients who even relapse in the hospital. That does happen. So anybody who has been introducing potentially foreign substances into their bloodstream, but also, back to his weeping central line in his neck, things we have to consider. So let's see. So we're going to think, we believe that he's septic. He's febrile. He's tachypnic, he's tachycardic. In the world of sepsis, two of your one of your most early indicators of the presence of sepsis is a respiratory rate above 20. The second most clinical indicator, sensitive clinical indicator, and most reliable indicator for ongoing need for fluid resuscitation is capillary refill. I can't remember and is there even a section for cap refill in the exam? Body tenderness, smooth tenderness. Okay. No, doesn't really say anything about his cap refill. So, as far as the sepsis bundle, we have the blood cultures. We haven't given antibiotics yet. We have a lactic level, which right now is normal. There's a reflex reassessment, usually in 3 to 6 hours. His hemodynamics right now are intact. I am going to go ahead and give him some fluid. I wish it had more specific options. Okay. Yeah, I have no idea how much I just gave him, but I clicked lactated Ringer's bolus. Sometimes people ask, like, hey, LR or NS, does it really matter? Not all that much. I'm an LR guy. I like LR. In old episodes of the podcast, we've talked about the potential or speculated benefits of LR relative to NS, but, apples to oranges. In a situation like this, it's really not going to matter all that much, especially in a patient that doesn't have, some underlying perturbation of their sodium or other. So we can see that we gave him that LR bolus and his heart rate did start to come down a little bit. I'm not sure, again, what that volume was. So maybe, let's give him another one. So, yep, he's liking that. He's liking that. We're getting some blood pressure up. So I'm sure this is something we're going to get dinged on at the end of this, but we have lactic, we have blood cultures, we have no other signs of organ dysfunction, we've got an EKG. He's not complaining of any chest pain. His heart rate now on the monitor does look a little bit more regular, so I don't know what that was before. We need some drugs. He is febrile, so let's give him a little bit of Tylenol. Not an option. Acetaminophen. Okay. Can have that. Sometimes too, oh yeah, temperature's normalizing pretty good. There's an ask your attending over here button if you needing a clue, but there will often be speech boxes that pop up that either hint at some things, or if the patient has a changing condition, it will point to that as well. So we gave him a little antipyretic, we've given him some IV fluid, now let's give him some antibiotics. But wait, what antibiotics do we give? Vancomycin. And I know we've mentioned this before, and I'm not going to go down this road too heavily, but antibiotic choice has many different, how would I put it? There's guideline recommendations, which you should absolutely follow, but a lot of those are heavily influenced by things like risk factors. So when we talk about a patient who's coming in with, let's say, community-acquired pneumonia, if it's me, a 37-year-old male with no significant medical history, comes in with community-acquired pneumonia, you're just going to go, I'm going to give antibiotic X. And let's say I don't have severe features. I'm not requiring supplemental oxygen. There's no hemodynamic disturbances, blah, blah, blah. Then I'm somebody who can likely be discharged on oral monotherapy or combination therapy if indicated, based off of things like local resistance or whatever the guideline might indicate. Then you go with that. Once you're an inpatient in the hospital, especially if you've been here for a couple of days like this gentleman has, he's got risk factors. So what's one of the primary things that we're worried about? Exposure to bugs like MRSA. So vancomycin right off the jump. If we were in an inpatient setting, one of the other things that I would do is I would order an MRSA PCR whenever, and we see this too in patients who come in with, let's say, like community-acquired pneumonia or maybe urosepsis, but we do believe they're septic, they're having hemodynamic changes, or maybe they're requiring vasopressors, so we're pretty convinced that actual septic shock is in play. You can check an MRSA PCR. You can obviously give them a dose of vancomycin, give them a dose of whatever broad spectrum coverage you think they need, whether you need, gram-negative coverage, anti-pseudomonal, blah, blah, blah. We've got, especially in the ICU, we have a pretty good box of things that cover all of those things. But in the name of antibiotic stewardship, we don't always want to just be slinging stuff like that around. So MRSA PCR is something like 95% sensitivity. If it's negative, your chances of having MRSA bacteremia are very low, very, very low. Not impossible, but very low, which is often when you read a note and it'll say, continue vancomycin and Zosyn, check MRSA PCR and discontinue if negative. That's a pretty standard feature. Now, obviously, if your patient's getting worse despite therapy, all those things, you can consider reinitiation of that. But ideally, you're taking steps to have a more targeted approach vis-a-vis we have blood cultures. Now, one of the things that we need to see if we can do is take the central line out, establish alternative access, and culture the tip of the central line. Let's see. Stabilize. So let me see. It might completely penalize me for some of the stuff, because obviously when we do these things, we're frequently thinking about what we do in the setting of the hospital and not the most ideal world. Now, one of the reasons I like this game so much is it does have, I think, a more rational approach that has a higher fidelity with what we do in practice. But sometimes you get through it and you get through the end and you've got it like a 65% and you're like, come on. So I am going to do insert IV, and then let's see, is there an option to culture the tip or take it out? Procedures. Remove central venous catheter. Yes. Oh, excuse me. Let's do that. Get it out. Cool. I wonder if there's a way to culture this tip. We've done the blood cultures. We've already looked through this list. I don't remember seeing anything in there. I don't see any indication for imaging right now. And I don't don't think there's any other bedside stuff. Lab works on the labs. Okay, I don't see an option for culturing the tip. So procedures, place patient isolation precautions. I don't think that's necessary right now. I mean, they're infected. I mean, I don't know. That's actually a good question. If a patient has, if you believe that they're infected in some way, should you initiate like contact precautions right out of the way? Well, I don't think so. He's not coughing, he's not sneezing, he doesn't have any diarrhea. He does have systemic signs of infection and localized signs of infection at the line insertion, but I'm just not going to click the button. It's going to be like, why don't you do that? Blood bank, did we gave the vancomycin, right? Okay, I'm actually also going to give him some cefepime. Some nice broad spectrum coverage. Ah, yes, I'm feeling much better. Now, I don't really think there's any other investigations that we need to do other than what we stated, but obviously I don't see any indication here that is this a single? Some of these require multiple diagnoses. Now, why did they? I'm trying to remember the exact reason they called the rapid. I mean, was it just tachycardia and fever? I don't know. So let's see. Do they have as a collapsing option? Central line associated bloodstream infection. So I'm not seeing any signs of septic shock, which is good. There are signs of potentially what we're going to diagnose as a central line associated bloodstream infection. We've gotten those blood cultures. There's, as far as I can tell, there's no way to check the tip of the catheter. So what's the dispo? Do we need to go to ICU? Do we need to go to cath lab, telemetry unit, discharge home? I would say he's not going home today. I would say he doesn't need to go to the ICU. He's got a stable tachycardia that was well responsive to fluids, which is good. Probably could use some additional fluids because I'm sure that this nondescript bolus is not going to cut it. And let's see, and his blood pressure is fine, but I think given the potential for worsening, let's keep him in the hospital, but I don't think he needs to go to the ICU. We'll go to telemetry unit, and we'll go with the diagnosis of, or we'll stay in the telemetry unit. We'll go with the diagnosis of central line associated bloodstream infection. Okay. All right, let's see what we get. Oh yeah, 97.2. So diagnosis is correct, disposition's correct. Now, I'm not going to go into the heavy detailed discussion component of this just because there's a lot of good rationale in there where if you wanted one, you know, I don't want to get, this is a product that I pay for, I'm not being endorsed, but I don't want to give away, you know, what's behind the paywalls. Like I would encourage all of you to go pay for this product. It's like $11 or $12 a month, I want to say, for basics. They have packages that you can get CME credits, but it's such a good tool. But we can see here in our review systems, 100% obviously, examinations 100% obviously, because we checked all the boxes. Stabilizations, we got 100%, attach monitor, critical, insert IV, and this is how it breaks things down. It will tell you if you've missed interventions or investigations, etc. It says neutral on the LR bolus, which I kind of get in the sense that there was no hemodynamic disturbance, but to maintain some degree of high fidelity, if we're in the hospital, we're concerned for sepsis, we're going to activate protocol, you know, and try and follow it within a degree of what is also would be helpful for the patient. When I say what I mean, that is, we're not always going to give a 3-liter fluid bolus to a patient with a heart failure history. Now, I have heard things like this verbalized, where someone might say, give it to him anyway. Worst case, you can take it back. Now, part of that's okay, right? Because if you're thinking, all right, maybe they're starting to get fluid overload and short breath, let's hit them with a dose of Lasix and that'll solve everything. Sometimes it does. But I think the more The more insidious variant of that statement is when people say, well, if they can't breathe, you just put them on a ventilator. No, we are trying to avoid ventilation, advanced mechanical ventilation as much as possible, unless it's absolutely necessary. In fact, serendipitously enough, if anybody's following Resus X by Critical Care Now, they've had several presenters who have mentioned the same thing. We're intubating too many people. Intubation is inherently dangerous and puts the patient at risk. It is something that temporizes until hopefully we can fix what's underlying, or we can optimize the patient so they can be liberated. But we want to avoid it at all, if at all possible. So when people say, just give them the 3 liters and intubate them if you need to, don't do that. So if you need to tiptoe your way through it a little bit, that's okay. So the one thing that we're short on are investigations. So ECG, we did, it says recommended, but we did one. BMP, we did. Critical 1 of 2. Oh, it's one we have missed. So recommended EKG, recommended Chem7, CBC, neutral on LFTs and MAG. Sure. Lactic, I wouldn't say that's neutral. I'd say that's important. Just because that is something you want to have a word in your head, because compliance with algorithmic medicine is very important. And I'm not saying that in the framework of you must be compliant to the machine. What I'm saying is, and people hate it, but it's true. Algorithmic medicine saves lives a lot more often than you do. And what does that mean? When you break down the data on decision making, especially in the healthcare setting, if you took somebody, and there are different books, there are different research portals that go through this, but if you look at something like acute coronary syndrome, I know a lot of you have heard me say this before, when you compare an algorithmic application of ACS care relative to just the discernment of the individual, more people die when it's just the individual, and we don't have a standardized approach. So get your lactic, just get it. Like it's not going to hurt anything if it's fine. But you might have a patient like this who maybe they're like him. They might have some degree of relative hemodynamic stability right at this exact moment. But then you see that and you're like, oh, it's like, it's 3 or it's 4. And you're like, okay, maybe you need a little bit more volume. Like, just because they're not shocky right now in front of your eyes doesn't mean that it didn't exist before you or it's not coming after you. So what did we miss? So chest imaging. So X-ray chest, CT pulmonary embolus. You should rule out other causes of tachycardia and fever, including pneumonia. It is also reasonable to be concerned for PE in a hospitalized patient, but this wouldn't explain his fever. PE can cause fever, but it is usually not as high as this patient's feature. So I'm going to push back on this a little bit. And part of that is because, the patient does have a tachycardia, and that is kind of a positive finding, but the patient doesn't have hypertension. So, I wonder if I can pull up another window. No, I'll just have to read it to you. So one of the tools that you can use, we've talked about MD Calc before, invaluable, use it. One of the things that you can use is something called Wells criteria for pulmonary embolism. And let's go ahead and actually apply it to this patient. So, and you can look this up on your own. Hopefully one day I can find a way to just paste this up onto the screen. But clinical signs and symptoms of DVT. Does this patient have any? Not really. PE is a #1 diagnosis or equally likely. I'd say no. Heart rate is less than 100. I'll say yes. Immobilization at least 3 days or surgery in the previous 4 weeks. So no surgery. Immobilization, I don't know. If we're doing good hospital care, this patient's up and moving. So if we're not and he's just been sitting around, then it's a possibility. Previously, so for that, I'm just going to say no. Previous objectively diagnosed PE or DVT? No. Hemoptysis? No. Which, mind you, hemoptysis is a late sign to you. Flashback to our previous episode on pulmonary embolism. Malignancy with treatment within 6 months or palliative? No. So right now we have one positive finding, which puts us in the low risk group, 1.3% chance of PE. Let's see. another study assigned scores as less than 4 as PE unlikely. And we can even say immobilization, yes, that's 3 points. Still, by the main risk stratification, it's a moderate risk group, but still the secondary study assigned scores less than 4 as PE is unlikely. In which case, when I look at this patient, I would say that PE is unlikely. The other thing you can do is the PERC rule. So that rules out PE if no criteria are present. And let's see. So age less than 50, yes. Heart rate less than 100, yes. Oh, wait, sorry. Age is greater than 50, no. Heart rate greater than 100, yes. O2 sat on room air is less than 95%, no. Unilateral leg swelling, no, there was none on exam. Hemoptysis, no, none on exam. None reported. Recent surgery, no. Prior PE, no. Hormone use, no. He's got 1. So it does say, though, if any criteria are positive, the PERC rule cannot be used to rule out PE in this patient, which is why Wells criteria is going to give you a little bit more. But I don't necessarily agree with that. Tachycardia, yes. No hypotension, no hypoxemia, no risk factors, no findings on exam. I would say no. And additionally, not that an X-ray or CT of the chest to rule out pneumonia is the worst idea. I would, again, push back on that because the patient is not hypoxemic. They don't have a cough. They're not expectorating anything. They're not wheezing. They don't have shortness of breath, not requiring supplemental oxygen. None of the findings in this push me towards thinking that there is an underlying pneumonia present. I think that they're great things to consider when your source is not floridly obvious like it is in this case. They've done everything but place giant neon signs throughout to say, this is what we think is wrong. Like, in my perspective, that would be an unnecessary investigation. Communications aren't integrated because we didn't need to consult anybody. Interventions were at 100%, didn't miss anything there. So, all done. Initial thoughts on challenges. So let me back out of here. Good. So hopefully this was helpful. I'd like to do more of these, trying not to give away too much paid content of other people's. Like I said, we're not affiliated with Full Code Medical Simulations, but I truly can't recommend this enough. It's fun enough. It's good enough that it's actually fun, that you can go through these, and it has a very high degree of high fidelity relative to different simulation things that you've done. Like, I'm sure a lot of people remember the old virtual ACLS mega code patient nightmare system that we used to have to deal with, which is just awful. This is not that. This is really fun. Do this, do Doctortal. There's plenty of case studies out there that are free. New England Journal of Medicine emails cases out, like, I want to say once a week, maybe. Pulm CCM does cases. Great stuff. There's no shortage of good resources out there. A lot of the times people just don't know what they are. So anyway, thanks for going through this. If you think this was helpful, drop a like, subscribe, drop a comment. Let me know. Was this helpful? Would you like me to do something else? I'm hoping to do more things like this in the future. Obviously, the podcast is still ongoing, but I think in the last 6 months, we've done a lot more talking than we've done clinical medicine. And we want to, at least on the back half of this year, start doing a little bit more clinical medicine and get everybody's brains engaged and asking questions and continuing to spread education through the system. So that's it. Thanks for watching. I really appreciate it. Thank you for all the support. It means a ton to us. And like I said, if you want to hear anything, want to see anything, just reach out, let us know.